you all for coming. I'm hoping that there will probably be a few more people who will show up. But one of the things we do with the seminar series is to record for the Open Courseware program so that we can reach a broader audience. And the last time we did this, some people who viewed the video talked about the noise in the hallway. So I closed that for now. But hopefully we will try to minimize noise. It's also a very hot day, so we'll keep the windows closed. But if you're feeling starved for air, let me know. So welcome. My name is Ndola Prata. I'm delighted to welcome to our campus today Dr. Ndola Prata. She's a public health physician and medical demographer, originally from Angola. She's an associate professor in residence of maternal and child health in the School of Public Health at UC Berkeley. And she's the scientific director for the Bixby Center for Population Health and Sustainability, and also medical director for the Venture Strategies Innovations Group. She's worked throughout Africa and Asia in many areas, including family planning, financing for reproductive health programs, the private sector's role in healthcare in developing countries, priorities for maternal health, maternal mortality, and the use of misoprostol for postpartum in obstetrics. She's a frequent flyer, so she just returned from a trip, and I just understand that she will be leaving again in less than a week. So this is a privilege to have her while she's in the country to come to Irvine and talk with us about her work. So please join me to welcome Dr. Prata.
Good afternoon, everybody. It's a real pleasure to be here at UCI. Especially invited by the School of Public Health to discuss some of the work that I'm doing. And Deli mentioned that I'm traveling. I'm actually going on Saturday to go back to the project that I will discuss with you today. So today, my plan is to talk with you about some of the financing and distribution strategies that we have put in place in the case of Ethiopia, rural Ethiopia, to increase community-based access to injectables. Usually my style of presentation is very interactive, so please feel free to interrupt and ask questions. Raise your hand if I'm going too fast, or if I'm using too many acronyms and you don't understand what I'm talking about. Is that okay? Okay. So just very quickly, a little bit of background on Ethiopia. It's a country in East Africa that is moving quite fast when it comes to changes in reproductive health. Sort of a contraceptive prevalence, especially modern methods, and I'm showing here so that you can see some of the more recent trends using the last two demographic and health surveys have increased. It's very interesting that most of the increase actually comes from rural areas. But there's still a large number of women who would like to use family planning methods, do not want to get pregnant, and are not using family planning, which is the definition of unmet need for family planning. Now, among all of the methods for family planning, most women in rural areas, and please note that Ethiopia is 85% rural, so most women in rural areas like the injectable contraceptive, and you will see as I continue this presentation some of the reasons why. And is not just in Ethiopia, but in most of rural Africa, is the fastest growing method of contraception. But in the case of Ethiopia, Ethiopia has probably one of the highest unmet need for injectables if you compare with other countries for which we have demographic and health survey. So in order to respond to some of those needs, especially related to the use of injectables, between 2008 and 2009, the Bixby Center, led by myself, we sort of tried to demonstrate if it would be possible that community-based reproductive health agents, which are community health workers that usually only distribute pills and condoms, could give injections because that was the method that women wanted to use. And to understand why we embarked on this, you have to understand a little bit my past. My past in public health has been always working with the lay healthcare workers, community workers, working with the women, working with communities, and empower them to use the easy-to-use technologies to improve their health. So please remember that giving an injection, you do not need to go to medical school or nursing school. Is a skill that you learn similar to knitting, cooking, and some other skills, probably more complicated skills. So what we did was looking at the safety, acceptability, and continuation rates of injections by the community health workers, and we compared them with the health extension workers, which are the health health system government sort of last provider that is in health posts that is by mandated authorized to give injections. Community health workers cannot give injections, only them, but they are in the health posts and women will have to come to the health posts. A lot of issues happen when women go to the health posts. There are two health extension workers per village in a health post, and they deal with all of the health issues of the communities that they serve. Child health, adult health, all of the diarrhea, all of the tuberculosis. If there is a meningitis outbreak, all of the issues, they deal with everything. So if you're a young woman that come to get an injection, you will probably be, as you can imagine, the last one to be served if the day doesn't end with women waiting all day there and having to go back home. So what we were trying to do is to see if the level of services related to giving an injection would be similar after training, of course, between these community health workers and the health extension workers. So over the course of 12 months, and following women through 3 injections, the injection is to be given every 3 months, we realized, as you can see from this graph, that the CDRHAs here are the community health workers and the hues are the health extension workers. So we realized that the community health workers actually could, over time, recruit a lot more women because, as you can imagine, they were walking and going to their homes while the health extension worker was waiting for them most of the times in the health post.
And
Yes.
these individual cases or repeat, so every 3 months, the women have to come.
Yes.
Are these numbers the same, do they include the same women coming 3 times or
Yes.
unique cases?
Yes. Yes, this is over time, so we followed the sort of more or less the same women. And you will see in the next one, because the importance of going back to the same women, it's very, very important to ensure continuation rates. And then also having in consideration why we're having discontinuation rates. Just to give you, our discontinuation rates, as you can see, were quite low. So we had some loss to follow up during the course of the study, but as some women have moved, some women, the husbands have moved to another village, and they moved. But we were able to, in these villages during this time, actually track down every single household to know what was going on. And basically, we were able to realize that the community-based reproductive health agents were doing, in terms of the safety, in giving injections, they were doing just as good job, and they could do even better job at continuation rates and recruiting, especially in the recruitment of new users, first-time family planning users. The issue with hormonal contraceptive methods that is also leads women to discontinue is the counseling process and the explaining the expected side effects. So these methods have side effects, and depending on the culture, in many countries where I work in Africa, women understand the side effects differently. You know, if you feel something once you take a medicine, you might understand as, for example, something, you know, that this medicine are giving you a different disease, rather than understand as a reaction to that medication. So we realized that the community health workers, because they had a lot more time to discuss these issues, did a significant better job at explaining to women what to expect, that when the side effect occurred, that they could quickly go back to them, ask more questions, and be reassured that it wasn't a new disease that they were having. It was something that could be manageable, and if not, we paid very careful attention to all side effects, and if not, that they will be able to then change the method without interruption, so that pregnancy wouldn't happen in between. So after we were able to complete this study, and this study was published in the WHO bulletin, and as part of, it was also part of a large technical consultation meeting organized by the World Health Organization, after which the World Health Organization put out statements about the countries with the low contraceptive use, where the preferred method of choice in rural areas was injectables, that they should go and increase community-based use of injectables. Now, the problem after you do this types of pilot project is, how do you scale it up? In the case of Ethiopia, for example, there are more than 7,000 community health workers. Now, who's going to train them? Who's going to pay their salaries? Because they work as voluntary community health workers. So who's going to pay their salaries? Who is going to do the supervision? You know, it becomes really overwhelming for healthcare systems that are already, you know, dealing with limited resources. But we felt like we had to work on models to scale it up, to address the two main problems: the distribution, so that, as you know, if you live in rural areas, they don't have pharmacies there. So pharmacies end where the asphalt ends. So where there's no asphalt, you won't find, for the most part, pharmacists, and if you don't have pharmacists, then you don't have these drugs available. Now we have to bring the drugs to the community health workers so that they can then do the distribution. But for us, it was really, really important, and this is more or less the landscape that we see in Tigray where we work. It's very, very important to decrease the unmet need. This is an area where unwanted pregnancies is very, very high, which leads to unsafe abortions, and those unsafe abortions have consequences in terms of morbidity and maternal mortality. It is also part of government strategy to increase contraceptive prevalence, but also, most importantly for us, by scaling up this project, we will be responding to women's needs and women's desire to use this method, given that pills and condoms were already there, but not being used the same way. So what we then needed to do, and this is a poster of Confidence, the social marketed brand of injectable contraceptive that is being used in Ethiopia. So what we needed to do is to test the feasibility to scale up sort of a model, because the social marketing is already well-established in urban areas, a very successful program. And then you have the community-based distribution of condoms and pills that are doing quite a good job in terms of distribution accessing women, but women actually want and request the injectable. So what we wanted to do is to see if we can marry both the community-based distribution and the social marketing, in a way pushing the boundaries of social marketing into rural areas, a little bit out of their comfort zone, because as you know, social marketers, they rely on existing infrastructure, so the shops, the small pharmacies or drug shops, rural drug vendors, etc. So we wanted to bring together both in a really sort of a public-private partnership, create this good public-private partnership to increase access to injectables. Now, the other problem that we found is like in the financing of injectables, we know already, because during our pilot we also did surveys that asked about the willingness to pay for the injection. And we know that in rural areas there's going to be at any point in time a certain percentage of women that will not be able to pay for the injection, especially something that, in rural economies where today you might have some disposable income, next month you don't have, and this is a medication that you actually need to have consistent funds available every 3 months. So what we were able to do is then team up with the Women's Tigres Association, which is a grassroots organization, and basically request that with some initial seed funding, if they could handle a drug revolving fund that started for injectable contraceptives, but then it could sort of evolve to many, many other things. So this partnership includes the Women's Degree Association, as I said, that basically handles all of the management, procurement of the drug through DKT Ethiopia, which is the social market organization. McKellar University and the Bixby Center, which are the sort of the two universities. So we train McKellar University to do the training of the community health workers and help us with the monitoring and supervision. And then the Tigray Health Bureau, which is sort of a public sector higher sort of a organizational structure, responsible for the health of the population. So, and this is a picture of all of us there. As you can imagine, there's a good balance right there in the leadership of this project. Basically what we needed to do to scale up this project is to train the community-based reproductive health agents. In the case of Tigray, they almost 1,500, and refocus the social marketing of Depot to include rural areas instead of focusing just on urban areas. We're starting by providing each individual community-based reproductive health agent with a stock of injectables, and that stock works as microcredit, like a microcredit loan, but in kind instead of money. And they took those injections home, so they sell, when they administer each injection, they sell it for 5 birr, the local currency, and they keep 2 with them, and they pay back to the drug revolving fund 3 birr, because that is the price that we actually purchase from DKT Ethiopia. So that takes also care of some of the issues related to just being voluntary, because these women now are making their own money. And the drug revolving fund would then address issues for adolescents that have no money to pay, and also for those months where certain women will not be able to pay. And I have to say that after a few months of, we started the project, the expansion in October with this model, and after a few months when we met with all of community health workers, some of them have given free injections, so they don't get reimbursed for the free injection, but they were happy to do that for now. And what we also did was we conducted a baseline survey, so we know the preferences, the fertility levels, where women would like to receive their injection. We also did a survey for the providers' characteristics, so the community health workers. And as you can imagine, there was a lot of controversy, given that 79% of the injection providers are farmers. So in the medical establishment, it was a crisis, because how can you allow farmers to give injections to other farmers? So, but usually doctors have those kinds of questions. They're doing very well. They're doing an excellent job. We have established a microcredit system and a revolving fund, so most of the women have already come back for the second, so they take in loads of 25 injections each time. So after training, they went home with the 25, and then they come back to their local, sort of at the district level, their local women's association, and they pay back the money for the injections that they took, and they receive again another loan of 25 injections. So the first cohort that we trained was about 100. The 31 were those who we sort of did a refresher course, because they participated during the pilot. So during the pilot, everything was free, but then they had to sort of learn the new processes. And in the first 3 months, they were giving about 6 injections per month on average, which was quite what we were expecting at that time. And of course, as you can imagine, the majority of their clients were new users of family planning. There is still a lot to accomplish in this project. This is a 3-year project. We are planning on actually training all of the community-based reproductive health agents in this area of Tigray. One thing that we still need to figure out is what is the sort of the fixed amount required for the drug revolving fund to sustain itself. Right now we have about 15% of users that are not paying for the drugs. So we estimated that the funds that we have for the drug revolving fund could run up to 20 to 25% free injections, but if for some reason we have more than that, then the fund will be in trouble, and we are really worried about raising the price of injections and losing, we expect probably 10 to 15% of users if we raise the price of injections. So this is something that we still are trying to figure out, but it gives us sort of it puts a lot of things in perspective, that some of these sort of concepts of sustainability are really, really difficult when you are addressing a major issue that can improve maternal and child health, but in rural areas, but at the same time, there is a financing contribution that needs to take place, and the populations that are being served are very, very poor. So sustainability, even when you have public-private partnerships, are going to become very, very difficult. But one of the good things that came out of this project is that in discussions with the Tigray Health Bureau, there are some projects to be put in place where the population is expected to have some funding contribution to their health care in general as part of the community health funds, using community health insurance. And the examples from this project could be a really sort of a good example to build upon as they move on to community health insurance for just general maternal and child health. So we still need to also demonstrate that this the project itself and then this methodology that addresses distribution and financing has the necessary acceptability from the population. That sort of the combination of the social marketing and community-based distribution, at least for injectables, can work. And what more can we learn from there? It is also important to note that even though we are trying by giving the part of the profits from the injections to the distributors themselves, that in their mind they will be using this after a certain amount of money, they will be using it towards their community. So the money goes back, that they themselves raised goes back to their community to do things that they would like to do in their communities, like buying another animal or more food or a vegetable garden or things like that. So they're not. It's a very small quantity, but at the same time, for them, it's that nominal fee is also a sign of the respect that we, sort of as part of the healthcare system, have for them, giving that a lot of what we do in the community is based on community volunteers. So basically, they get absolutely nothing except when they come for training and there's refreshments and lunch and things like that. So I am going to stop here and thank you and open up for discussion.
So I have the public-private partnership. I think it looked like it works in this case, but my question is about the message and the perception of this mode of I guess prophylaxis. What is the word? Prevention of pregnancy. How does the cost compare between the injectables and condoms? And the idea that in another program is giving out the message about pregnancy prevention should be linked to disease prevention, especially maybe HIV transmission might be effectively controlled by condoms, whereas injectables, this may not necessarily be the case. So is the partnership to combine the two as opposed to just combining the strategy of delivery and financing, that the messages are not conflicting when we talk to the women?
Mm-hmm. Oh, thank you for the question. You're absolutely right. The messages are not conflicting. They know during the counseling that the community health workers tell them that injectables does not prevent against disease. And some of them have the dual protection. The problem with the condoms is an old one that you all know. It works even in rural areas much better for pregnancy prevention or disease prevention in occasional encounters, but it doesn't work very well with regular partners, including husbands. There's a lot of resistance from partners, especially the men, to use condoms for various reasons, and women, as they explain to us, that they have difficulties making their partners use the condom. So in that case, they basically have no protection whatsoever, not for disease and not for pregnancy prevention. And they really prioritize pregnancy prevention, especially when they are in stable relationships. Now, there's a lot of women, I didn't show the data here, but there's a lot of women that actually take home both. So they use both. But It is also important to note that this is a quite low contraceptive HIV prevalence community. So even when we talk about, they understand the risks, but you have to understand that for them, unwanted pregnancy, which is associated with a huge amount of stigma, is a more pressing issue for them. And that's why they desire some method that is non-coital dependent. It gives a certain length of protection rather than, for example, taking pills every day and not having to have the cooperation, so to speak, of their husbands to do. So that's why it becomes, injections become a very sort of important method for this group of women. But it is important.
And so even if condoms are cheaper,
They are cheaper.
they're not sustainable for a completely different reason, which is the acceptance and
Yes, they're not just cheaper. Condoms are being distributed
for free. That's quite funny.
And so are the pills. And the worst part is they have injectables also at the health post. But due to convenience and trusting basically the neighbor that gives the injection, they would rather pay than walk to the health post. And so in some instances, they actually, some of the community health workers say, wait, why do you think they're paying? They say they're paying for the privacy of the method. There's still a lot of issues related to fertility and how many children, the expectations of how many children these young women need to have. You also have to remember that these women marry quite early. They start childbearing at 15, 16. So by the time they are 30, they might already have 5 or 6 children. So, and the injections are sort of, as they say it, their preferred method. Even though in some areas where we are now trying to pilot the implants, the single rod implants that the health extension workers in the health posts can do, some of them are switching, especially those who don't want to have any more children, not the ones that want to space. So there's quite a bit of switching going on, which is okay. They sort of are switching from the depot to a more sort of a long-acting method.
Questions?
I have a quick question. Just to be clear, the community health workers, are those people from the rural areas? So they're, okay.
Yes, they are. And they do, in this particular case, I mean, throughout Africa, they might do various things, but in this particular case, they do a lot of health promotion. They actually started by the government to improve sort of a basic hygiene and knowledge about, for example, not sleeping with animals in the same hut, to sort of have some distance, breastfeeding, teaching mothers about breastfeeding, how best to use the local nutritional sort of elements to incorporate in their diet and things like that. And over time, we basically started to add more and more as the need was growing, more tasks to them. But usually each village might have 4 or 6 community health workers. And they have, also in Ethiopia, they have what they call the coffee ceremonies. So where a lot of women come together, and then there's the roasting of the coffee and serving of the coffee, 3 or 4 small little espressos. And it's during that time there's a lot of discussions about health and reproductive health specifically takes place. Yes.
So did you find the need at all in educational programs to educate any of the males within the family?
Absolutely. It's a work in progress. We continue to educate, and we actually found avenues. We have in the project 3 priests, Orthodox Christian priests, that are also community-based distributors of contraceptives, and they do also a really nice job at involving men in the discussions, the importance of sort of spacing for the benefits of the mother and the children. So but what we were able to do during this education campaigns, apart from what the billboards say, is to give the local communities, those that have a louder voice and are trusted by their communities, the ability to explain all this, the ability to just not, oh, we need to reduce fertility, you know, you're having too many children, but to have a more sort of a health rationale, maternal child health rationale to family planning. And that doesn't mean that everybody agrees with it. It doesn't mean there's a lot of women that are part of the category that we call covert use. So basically, we know that their husbands don't know that they're using family planning. And that is something that you know, community health workers know and do that, you know, continue to provide services in privacy, not to put their sort of a health at risk.
One more question. So when you looked at the baseline, I'm guessing you probably saw some crossover between, you know, after the program was implemented, some crossover between people who were taking other contraceptives, and so the demand for, you know, injection increased. But what was the overall demand increase from the baseline after the program?
Oh, we haven't. We just have the baseline.
Okay, so
we haven't measured yet. So we are planning on measuring after 3 years.
After 3 years.
Yes, we haven't measured. So what we saw is so a desire to change.
Mm-hmm.
Of those who wanted to use, which is you know 67% of women of reproductive age wanted to use family planning methods, and of those wanted to use, the vast majority wanted the injectable. But that is at this point in time. As other methods and they move in their reproductive life, they're going to need and want other much long-term methods. So the injectables are, you know, it's a quick response for now, but it's probably not going to hold forever. Because very quickly, you know, in the late 30s, they already don't want to have any more children. And at that point in time, they don't want also every 3 months to get an injection. They want something more permanent.
I lied, I have one more question.
Yes.
So has there been any sort of just general economic analysis of the cost of implementing this program, you know, versus the cost of not implementing this program and dealing with all the health repercussions?
Not that I have complete numbers to give you, but that is something that is part of our project. So we're tracking costs. So including what, you know, they're taking their time voluntarily, but we're tracking how many hours a week they actually spent on this project, and we will do the economic analysis. But I can tell you that it's going to be a substantial difference in price. I mean, there's many studies that you can find looking at return on investment for family planning programs in general, even those that cost quite a bit. Even in California, we have Family Pack has one of the best sort of in America family planning services, and even though we spend, you know, hundreds of thousands of dollars more than in any family planning program in sub-Saharan Africa, it's still a very important return on investment. You shouldn't quote me on this, but it's something like one sort of you receive back $100 for every dollar that you spend.
Which would be spent on infant mortality and
Yes, yes.
maybe
Education
special
programs, water and sanitation, I mean, not just health, but also other social programs for which, if these children are born and survive, will need services.
You talked about scaling up, and I don't know, one of the things I guess you would build into your training program is, let's say for example, this is a very highly diverse society in terms of language, maybe some subcultural issues that you may have to train differently. How is this region in that respect? My sense of Ethiopia, and I've never been, is it's pretty homogeneous, but in other parts of Africa, you might go from one village to another and it's a whole different.
Yeah, no, in Ethiopia too. This is this region called Tigray is mostly Christian. There's a little bit of a very small percentage of other religions, but in other places, in other regions of Ethiopia, you have sort of a much diverse with different needs and different sort of perspectives on family planning that would have to be addressed. One of the things that is cross-cutting among all ethnic groups in Ethiopia is their desire to have fewer children. That has, you can see from demographic and health survey to demographic and health survey how it's going, the desire for families is increasing. So the number of children, and they're having more children that they actually want on average. So it's just sometimes how to deliver the message, family planning message that is non-threatening to the different sort of ethnic groups.
But you train in English, the university. Your training program is in English, or?
Yeah, and they put it in the local language. Yes, yes. All of the materials, all of the things are in local language. And even, for example, the education portion, we don't really script what to say. They actually teach us what to say. We give them the knowledge of what it is that we want to achieve. And then they tell, okay, so here's how I would say it.
Well, if there are no further questions, we have a little thing for you that you take on your travels. It's a mug for water, or it's too big for Ethiopian espresso, but you might try that.
You put 3 or 4.
Yeah. So please thank Dr. Prata for